So I'd like to tell you a little bit about the combination of enasidenib with azacitidine in patients with IDH2 mutated AML. So just as kind of a bit of a background and a reminder, IDH2 mutations happen in about 12 to 15% of our AML patients. And in general, they're happening in our older patients where kind of our non-intensive chemotherapy strategies like azacitidine tend to be our standard of care. And so what this clinical trial was doing was randomizing patients to receive azacitidine alone versus azacitidine with enasidenib, which is a FDA-approved oral targeted IDH2 mutant inhibitor. And it was a international study, and it was a 2-to-1 randomization that was not blinded. About 100 patients were enrolled, 2-to-1 with the combination getting enasidenib with azacitidine. And again, it's as you would expect for kind of a older patient population. The median age was 75 in this study, and about a quarter of patients had secondary AML. The primary endpoint of this study was looking at response, and indeed the response rate with that combination was quite significant. So compared to azacitidine alone, where you see an overall response rate of about 40% and a true CR rate of only 12% with azacitidine alone, we saw a overall response rate of 71% with a CR rate of 53%. So a true CR meaning full count recovery with that combination. So that is really quite compelling. And in addition, the duration of response in people getting the combination was over 2 years. So people with an IDH2 mutation that are getting this combination are having really durable responses. In terms of safety, the key safety thing to be aware of when you're using the IDH inhibitors is there's a risk of differentiation syndrome, which is a kind of a constellation of symptoms where you can have shortness of breath, effusions, infiltrates. It often happens about 2 to 4 weeks into therapy and is treated with steroids. And so very similar to ATRA-related syndrome in patients with APL, which the audience is well aware of. So very, very similar to that. So just something to have in the back of your mind in a patient who is put on an IDH inhibitor and who starts to develop some usually pulmonary symptoms. Think steroids for differentiation syndrome. In terms of outcomes like event-free survival and overall survival, the event-free survival showed that there's starting to be a nice splay between the two. So with azacitidine alone, there was an event-free survival of about 10 to 11 months, and with the combination, 17 months. And so people on the combination were staying on a bit longer. That's not yet statistically significant. And median overall survival, interestingly enough, was impressive in both arms at 22 months, but very similar. And so one thing that's kind of an interesting aspect of this study, I think, is that because it's not blinded, some people who were randomized to azacitidine alone who did not have a response within the first few cycles potentially came off the study and was able to receive enasidenib or other targeted therapies like venetoclax in the relapse setting, and were able to then attain a response. And so just something to keep in mind is we're getting more and more effective therapies in AML. EFS versus OS tends to be, an important consideration. And so there's more detail that I go into in the presentation about kind of the depth of remission and the variant allelic frequency of the IDH2, which are really interesting, but a bit kind of outside the scope of this talk, I think. So the end result is, I would say, 1, make sure you're looking at genomic annotation of your patients with AML, because if you're not aware that they have an IDH mutation or a FLT3 mutation, you're not going to be thinking about these targeted strategies, which are very effective for them. And then 2, this combination of aza with enasidenib was really quite effective. Dramatic improvements in complete remission and overall response rates. And it was a smaller study, not powered for survival, but indeed the outcomes were quite impressive. And so with that, I will close, and thank you for your attention.